Good afternoon, everyone. My name is Jan Colon. I am the Director of Education at Lutheran Health Network, and proud to say I'm part of the TB Consortium, which is made up of Parkview and the Department of Health. We've been together now for many years, and we're always excited because what we've done is collaborate also with the CIDNAC annual event to bring both of those groups together to focus on infection prevention in our community and our region. So we're pleased that you're all here for whichever reason you've came. So thank you for being part of today. Before I forget, I want to thank Dr. Steinecker, wherever he is down here. He helped to make sure that we had this lovely location as far as snacks for you today, so thank you for that. Appreciate that very much. So let me share with you a little bit about our agenda. This is very interesting because I got lights in my eyes. I can't even see you. Are you out there? I've not had this experience before, but it's interesting. So I know you are. I know you are. So our agenda today is, just a minute, I got a new tool here. Anyway, you know what? Let me tell you what the agenda is today, because my slide isn't advancing, but that's quite all right. First of all, we did have our TB instructors here today who've already done their updates, so thank you all for being here. One of our goals is to ensure that our TB instructors are proficient in administering reading, so they're teaching others to do it correctly. So we're very committed to that, so they've already done that, so thank you, instructors. We're going to then hear from Dr. McMahon, who is our leader of the TB Consortium in CIDNAC, so we're always appreciative of what she does for us and contributes to the community. So she's going to update us on tuberculosis as well as MERS. So it's going to be a really helpful thing because those are both still really relevant infectious diseases that we need to stay on top of. We're also going to hear, and I hear people talking about this one, pus in the belly, which is going to be an unusual TB case. So Dr. Melendez is joining us, so thank you for doing that. We can't wait to hear more. We're going to also hear from our Dr. Steinecker, who is part of the TBC, to hear a little bit more about IGRA, to be or not TB, the IGRA interpretation. As we've been together, we have seen the evolution of how IGRA has become part of how we are diagnosing and part of our process for how we identify tuberculosis. So it's added something new to our toolkit, so to speak, to how we can do this well. They're going to have a break. We do have some snacks hopefully left for you to enjoy. And then we're going to hear about the emergency response and lessons learned in Scott County. We have somebody, Caitlin Conrad is joining us. They apparently had some interesting events down there that related to HIV, but also trickle back down to thoughts of tuberculosis and how infection can just mushroom to become something bigger, and we don't want that to happen. We want to learn from what they learned in Scott County. And what I'm learning is, I know you were all interested about a dangerous mani-pedi, but unfortunately that presenter is not able to join us today, so we are going to hear from Kathy Thornson. She's the HIV STD director at the Allen County Department of Health. So she's going to provide us some updates in that area as well, which again, keeping on our toes, making sure we're aware that we got to be alert at all times. So we got a full agenda of very appreciated speakers who are going to share with us their expertise, and hopefully you all learn and become better at what you do based on your experience with us today. So just a real quick update of the TB Consortium. We continue to work and meet together, which is one of the most awesome experiences. We were just talking about the collaboration with Parkview, Lutheran Health Network, and the Department of Health. There's not that many opportunities for us to work to be on the same page throughout the region, and it's been really a blessing and a great opportunity for all of us who have been involved, and hopefully, ultimately, for the people in our region who we can help prevent the spread of TB and other diseases. So that's really been very fabulous. But what we're working on right now, we did put our update online for those of you who are TB certified, and that has gone well. So we are excited that we've accomplished progressing to the electronic world and how we educate. We're also going to start to begin to work with our long-term care facilities. We have a meeting with all the administrators because we're not certain what their process is for training their TB instructors. So we want to partner with them and bring them in to the fold so we can be more consistent with how we get that done to once again keep track of tuberculosis. We cannot let that get out of control. So that's a little bit about us. Not a lot of big changes this year, but we're still on it. We're still heading the right direction, wanting to do that as well. So I'm going to turn it over. We're going to get started, and thank you to all the TB Consortium Steering Committee who are out there who have been part of planning this day as well. So Dr. Steinecker, I'm going to turn it over to you.
Well, hello everybody. Parkview Health welcomes you to our facility here at the Mirro Center. Just a few housekeeping notes. If you go through the back doors, on either direction you'll find sets of bathrooms. Additionally, if in the case of fire, you'll follow those same exits and go out and we'll be able to exit out of either end. And then there are also fire exits up here that you would be able to exit out of as well. You can also exit through this conference room to my right, your left, and there are doors on the other side that also lead to additional exits. Snacks are in the back and are available as well, as I think most of you have already found those. And with that, I'm going to go ahead and start by introducing Dr. McMahon, who's our health commissioner for Allen County, and she is going to bring us our TB and MERS-CoV update.
Welcome, everybody. I'm glad you're all here today. Appreciate everybody taking time to be here. But Dr. Steinecker, I must ask you, were you a flight attendant at some point in, I don't know, I mean, you were pretty good with that, pretty magical. Thank you for hosting us here. The good news is you have a nice environment, you've got snacks. The bad news is now Mindy wants a baby grand piano for our office. So, you know, I guess you take what you can get. Do you want to do this stuff? All right. Is it? You think it's on? Oh, it's on. All right. Well, I'm going to go a little bit out of order. Is this pretend or does it work? It's like the thermostats on our wall, Mindy. They're decorative. There you go. Oh, did I do it hard enough? Or? Okay. First, I want to talk about MERS. I think, you probably all heard about what's going on in South Korea and all of those outbreaks in where is it now, Saudi Arabia. So I want to talk a little bit about that, remind you about MERS, even though it's been around for a little bit. I'm going to kind of slip in a little bit of information about Ebola and chikungunya, and then we're going to end up talking about TB and Allen County and really kind of bring you up to speed with what we're seeing here in Allen County. Boy, I'm really on. I was given a talk, I don't know, maybe a couple of weeks ago, and I was talking about travel and how you have to prepare for travel, and it really occurred to me that my singular job is to suck the fun out of everything you want to do. And I realized, man, there's nothing you're going to suggest to me that I'm not going to say is dangerous, and you either need a helmet or mosquito repellent or a vaccine or something. So I just want you to remember that. The fun stops here, okay? But we'll start with MERS. And as many of you remember, this really started in 2012. That's when we first started seeing this, the Middle Eastern Respiratory Syndrome. From now on, we'll call it MERS. It's caused by a coronavirus, very similar to what we saw with SARS like a decade or so ago, if you all remember that. And it primarily affects the respiratory system. And again, was first identified in Saudi Arabia in 2012, although I guess now they're believing that actually the first case probably occurred in Jordan shortly before that. And so far, all of the countries have been linked to or near the Arabian Peninsula. There have been cases other places, but they had traveled to that area first. The incubation period is kind of what makes this a very challenging disease to diagnose. It's usually about 5 or 6 days, but it can be as long as 2 to 14 days or 2 weeks. And the age range is anywhere 1 to 99 years of age. And like I mentioned, it primarily affects the respiratory system. We see this presenting very much like a SARS, where it's a lower respiratory infection, fever, cough, and shortness of breath, progresses to ARDS and more inflammatory types of responses. There can be complications seen in a lot of people, including pneumonia, bacterial pneumonia, and then kidney failure. So this is kind of the spectrum of the illness. And it has a fairly high, just like SARS, has a fairly high mortality rate of 30 to 40%. There are people that they believe are infected and either have very mild or virtually no symptoms and recover. And the people obviously at most risk for having severe outcomes are those with pre-existing medical conditions. And those are things like diabetes, cancer, chronic lung and heart and kidney disease. Those people have been found to have more complications. And of course, immunocompromised people are more likely to be infected as well. Transmission, it's thought to spread, as we would expect from coughing, the respiratory secretions. Thankfully, we know that this is not like flu. It's more like, again, SARS. It's a lower respiratory infection, so it's not easily spread from person to person, so you don't see a lot of community transmission. It's thought, again, kind of like TB, very close contact with people is how you're become infected with this. But we have seen most of the transmission comes in healthcare settings, and that's why I thought it was kind of important to talk about that today. And even like in South Korea, there wasn't a lot of community transmission, even though they were seeing all of those cases. Most of the cases stemmed from contact with people in a healthcare facility. But I think it's really important to say, too, we really don't know precisely how this virus spreads. The reason I think it's important for us to talk about this is, where did the first case of MERS in the United States occur? Indiana, of course. Indiana and Florida. We were the first two cases of MERS in the United States, and those were in healthcare providers who had just been in Saudi Arabia and had been infected there and brought it back here, and then presented to healthcare here. Both were hospitalized. They both fully recovered since that time, and they investigated about 500 people and found no other cases in those people that they had contact with. So again, that's comforting in the sense that we know it's not really easily spread from person to person. South Korea, I want to take a little bit of time because I think there's some lessons learned, even though their healthcare system is a bit different than ours. Ironically, their healthcare system is more easily accessible than ours is. When one article I read, it's very low cost, everybody, it's free, well, low cost or free, and so everybody has access to healthcare systems. And in one article, they likened it to a lot like shopping. So it's kind of like, do we want to go to the mall or do we want to go to the hospital? So they look at healthcare a little bit different. There's no copay in South Korea, and that really promotes a lot of people going to the hospital and a lot of crowding. So keeping in mind that their healthcare system is different, I think there are enough lessons to be learned here that we need to consider here when we're seeing patients here in our community. The first case of MERS in South Korea was reported on May 20th, and it was a patient who had been at a meeting in the Middle East, I think it was Saudi Arabia, and they were infected there, and then they came back. And when they came, they went to at least 4 healthcare facilities that we know of before the disease was identified, because they had no reason to be suspicious. Apparently he didn't provide a travel history, so he went to multiple, and this was a pattern seen in a lot of the people that were infected in South Korea, was that they visited a number of healthcare facilities before they were diagnosed. Part of that is thought to be because of the long incubation period. By the end of this, at least 30 hospitals have been involved and identified as sources of transmission of MERS in South Korea. And there have been a couple different studies looking at, well, why did we see so much of this transmission in the hospital? What happened here in South Korea? Because again, they have fairly good health care and very easily accessible health care. What happened? Where was the breakdown? And there were a number of factors that they believed were associated with this. First of all was a delay in identifying the index patient's infection. Because remember, how do they present? Like with every other respiratory illness or viral illness, fever, cough, and then as they progress, they develop the shortness of breath. So initially, they may just have a cough. Well, how many people do you see every day that have fever and a cough? So again, you can see maybe why there was a delay. Now, I don't understand this. I understand the relatives sleeping with people in the hospital. I'm not sure why the healthcare workers are sleeping with the patients in the hospital, but let's say that's a South Korean phenomena there. But so that there are a lot of people in very close contact, just like we said, it requires that close contact, not just passing by. And then they tend to move people around quite a bit to wards. They have multiple beds. They have kind of like the old wards like we used to have. Remember, I don't know if any of you are old enough to remember when you did your rounds, there were like 8 people. I'm sure Dr. Melendez has no idea what I'm talking about, but a ward would be like 8 people separated only by curtains. So I think that's kind of still vogue there. Again, the people seeking care in multiple hospitals, clinics, pharmacies, again, people were they were sick and they weren't getting the right diagnosis, so they kept doctor shopping. For one lady, she had an 8-day interval between the time she first developed symptoms and actually she ended up dying. And she went to 4 hospitals, an Asian medical clinic, and 4 pharmacies before all said and done. So you can see all the possibilities for transmission in that time period. Well, we know now that 4 generations of infection have occurred with MERS in South Korea, and 89% of the infections appear to be linked to 3 hospital-linked super spreading events. And I think we need to spend a little bit of time on this super spreader because we've seen that in other types of infections as well. And they think that these events are really stem from a couple factors, including the level of virus shedding. And there have been some immunologic studies showing that some of the sickest people have a really high viral load, which kind of makes sense, but it's not like everybody has the same amount of virus. And they think that the more virus you have and the more shedding you have, the more likely those people are to be infectious and infect a lot of people before all said and done. Contacts rate, how many people they're in contact with, the hospital procedures and the location of the hospital, some were more sophisticated and urban and some were more rural, and so they didn't have the infection control measures in place, and then population structure and population density. All of those thought to be involved in identifying those places where a lot of transmission occurred. As of June 30th, about 20% of the 182 MERS cases in South Korea occurred in healthcare workers. So again, I think that's something important for us to remember. One of the factors, another study looked at transmission, and one of the factors that contributed to the spread of the virus is that the country didn't expect to see MERS and the doctors were unfamiliar with the disease. That's why people were seeking health care in a variety of settings and oftentimes had visited, like I said, many places before they were finally diagnosed. The hospital infection prevention and control measures weren't optimal, and extremely crowded emergency departments and these wards, these multi-bed wards, all of these things really facilitated nosocomial spread of the disease. But there were 2 factors that really facilitated transmission: the doctor shopping, and I don't even know if it's doctor shopping, it's really just going to try and get better, and you're seeking care at a variety of places until someone can give you an answer that makes sense or you start feeling better. And then having these many family members and friends visiting patients on medical wards and just a number of contacts. And the crowded in the emergency room, they don't have logs of the people in the emergency room, so if they identified a case that had been waiting in an ER waiting room for a long time, they couldn't identify the people that had been around them. So again, their systems are a bit different, but I think you can see some similarities here. You know, I think we've gotten really good as a community to say when we see real peak flu season, we really limit as a healthcare community, we start to limit admission. Don't bring people, limiting visitors to the hospitals, limiting kids going up to the wards. And I think that's really smart. You need to do that because you don't want to spread it in the community by exposing all these people or making the people in the hospital sicker with something else. Right now, when we look at the countries in or near the Arabian Peninsula that have MERS, it's Iran, Jordan, Kuwait, Lebanon, Oman, Qatar, Saudi Arabia, and the UAE and Yemen. Those are some places. I probably wouldn't want to go there for a lot of reasons, but right now that's where we're seeing a lot of the MERS cases. But then you also have the travel-associated MERS cases, and the U.S. is one of those countries. Infection control, I just want to remind you that measures that really enhance that early detection, that's really going to, and then the isolation of patients once you're suspicious of this, and then implementing all of your precautions that you need, standard droplet, all of those things, and contact precautions, implementing all of those things are what really limit this transmission of it, not only in the hospital, but obviously in a community. But I think again, the reason I really wanted to talk about this today is because I think what we learned is that if you aren't suspicious of it, it's going to be too late by the time you figure out what somebody has. And so it all starts with that travel history. And I've been saying that now for a couple of years because there are so many different diseases, whether it be Ebola, whether it be MERS, whether it be chikungunya. It really depends. You're making that diagnosis. They're presenting with very similar signs and symptoms. Without that travel history, you're not going to think of MERS. So it's really critical that you make sure that it's just an automatic part of history taking now, even before they get back to the room. You want the triage folks to know if that person, if they've just been to Jordan and they're in with a fever and a cough, I would hope that you guys would put them in an isolated room and then go from there. So we need to think of this. It's not like those doctors in South Korea had never heard of MERS. They just didn't think of it being in their hospital, in their ER. We need to think like that. And the way you're going to do that, the way you're not going to miss, is getting that travel history. Saudi Arabia is now right in the middle of another outbreak. You know, Korea has really finally settled down. They're having some sporadic cases here and there, but now Saudi Arabia has a number of cases. And again, the mortality rate is not insignificant. 44% is pretty impressive. Those are the cases, of course, that we know about. Again, if you have subclinical or very mild disease, those aren't in the denominator by and large. So, you know, I'm certain that as we become better at diagnosing it and reporting it, et cetera, that fatality rate will slow down, but I think it'll still be unacceptably high. I'm going to give you just a little bit about Ebola. I know you're all dying to hear about it. As of June 27th, there were almost 30,000 cases of Ebola, including 11,000 deaths. Very, very sad. It all started in West Africa in December 2013. There have been 10 countries, including the U.S., that have had cases. Guinea, Liberia, and Sierra Leone experienced the widespread and intensive transmission where most of the cases occurred, obviously, in 2014. Good news, Liberia was declared Ebola-free on May 9th. Of course, they just had another new case, so now we'll have to see where it goes where this goes. Low-intensity transmission continues because, again, they just don't have the public health infrastructure there to be able to do what we do, which is identify, contain, mitigate, do all of those kinds of things. They just don't have it. So, again, I think nobody's really sighed a deep breath of relief yet because we know that there's still disease gurgling around in that community. The area of transmission has expanded slightly in recent weeks, and for the first time in several months, 2 healthcare workers were infected. So again, I don't think we're really out of the woods yet with Ebola. Again, they're really concerned about the reemergence of this disease. Even in really good times, they don't have really access to all of the things we have, like gloves, and you know, they re-wear gloves and they wash them out and hang them up on I don't know if you saw that, where they hang them on the clothesline to dry and then use them again. That's in good times. So I can't imagine they've just been ravaged by this ongoing outbreak for so long. You know, the concern is, do they have the tools they need to prevent a reemergence of the infection? And I think the jury's still out on that. We continue to monitor travelers from Sierra Leone. Actually, we're doing 2 now. Sierra Leone and Liberia, where? Guinea, Sierra Leone and Guinea, that we're still monitoring those patients, doing active monitoring. When they come back to the United States, we're notified that they're here, and then for 21 days, Erica or someone else from our staff will call them and check their temperatures twice a day. So we're still doing that monitoring. Talk a little bit about chikungunya. Has anyone had any patients with chikungunya? I got 5 minutes? Okay, chikungunya, it's bad stuff, mosquito repellent, you need to use it. Okay. TB. In 2014, we had 6 confirmed cases in Allen County, age range 20 to 68 with a median age of 45. Most of them were male. In 2014, 100% were foreign-born. And when you look at, most of those came from Burma, which I think you're probably not surprised by, but we did have some other folks represented. What I really want you to take home from here is only half of them were pulmonary. The rest of them were lymph nodes, testicles, bladders, et cetera, et cetera. TB is the great masquerader. It used to be syphilis was the great masquerader. Now TB is a great masquerader. You need to think TB. This year already to date, we've had 5 cases, so I'm a little concerned that we're going to have a higher rate than we did last year. And remember, as our rate goes up, that means you have to re-implement your TB skin testing or your TB testing for your employees, so we want to keep that rate down. Age range, again, it's young 20s to 70, median age 46. Males, we had 1 woman this year, but only 80% were foreign-born. And here we had a wide range of people so far this year: Burma, Bosnia, Mexico, Africa, and we had 1 American person so far. So again, you have to think TB, because again, only 20%, 1 person had it in the lungs. The rest of them, it's been really unusual cases. And you're really going to hear from Dr. Melendez how you need to be a great medical detective to find this disease so that we can treat it. Our incident rate was 1.4. In Indiana was 1.4 per 100,000. However, the U.S. born, just looking at U.S., is 0.7 per 100,000. We're above the national average in terms of foreign-born people with TB, but we're also above the national average in people completing treatment for TB. Glad to know. World Health Organization is still a big problem, third leading cause of death. What's new? We've got some new testing on the way that I think that it's T-cell testing that I think will be very helpful in expediting the diagnosis and making us even more able to start treatment and what it's sensitive to pretty quickly, and how they're progressing rather than just waiting on sputum, which is very tedious and not always productive. Remember, PCR testing is done by the state. If you have a specimen, even if it's not or smear positive, if it's someone that you're really concerned about TB, send it to ISDH. They'll do the PCR testing, and we can jump on treatment as we need to. The new treatment, I just want to talk about, we have a new treatment for latent TB. We love it, don't we? Don't we love it? Doesn't Ruby love it? She starts new people on it every week. It's INH and Prifton once a week for 12 weeks, and you're done with latent TB. That is so much better than INH for 9 months, and so much easier to sell for people, that treatment regimen. People do very well on it. There are certain people that you don't want to use it on, but by and large, it's been very well received by people, and they do very well with it. It needs to be observed, though, because it's such an abbreviated treatment. They need to be observed, and so we can either do that by having them drop by the clinic, or we go to them once a week. There's Phil, he's one of the people that drops off the TB meds, or we can actually do it via video phone if we think that those people are reliable. So we can get the medicine, it's free, we can get them to them one way or another, and there's no reason why we can't treat most people with latent TB now. And we've had a really high completion rate. We've had a few people drop off because of side effects, but very few people, and by and large, I think people do really well with the treatment. We're supposed to, at some point, there's going to be a new reporting rule where it's going to be, LTBI is going to be reportable. It's still not passed yet. I don't know anything else about that. And hepatitis C, are you going to talk about that, Kathy, at all? Hepatitis C. So let me just tell you, Caitlin's going to be talking about what's going on in Scott County, which I think you're going to find very interesting. But we've been monitoring with all the IV drug abuse here in Allen County. I don't know if you're aware of that, but we really do have a significant issue with IV drugs, especially heroin here. And so we're really looking at our hepatitis C cases, and we've had about a 20% increase in the number of people with hepatitis C. And Kathy's going to tell you about our HIV later on, but just to know that we're going to be intensifying our evaluation of people with chronic hepatitis C. We're working with ways to get people into treatment. It's just, unfortunately, as you know, so very expensive. But we want to make sure that if we're seeing a trend of increased hepatitis C with IV drug use, then we're going to have to really start doing some more non-traditional things like maybe a needle exchange program. So people are traveling all over. Get that travel history. It will really help you in making a good diagnosis and a timely diagnosis, and it'll make your infection control practitioner so happy, because then you will minimize transmission. It'll make us happy. It'll be a much better place. And just remember, if you think about doing something fun, just remember, what would Deb McMahon say about that? Okay? With that, did I finish timely? All right, thank you. Well,
All right, thank you very much. I'd like to introduce Dr. Melendez. Andre started at the Indiana University School of Medicine. He then took a detour to University of Colorado, where he did his residency and internship, and then went to Emory University to do his fellowship in infectious disease, just as I had. So we welcome him to come up and talk to us about pus in the belly.
Right, it is kind of bright up here. Pleasure to be here to talk to you about a really interesting case, probably the best one I've had here last year at Parkview. So, I've titled it Pus in the Belly, and a tenet of infectious disease that pus never sleeps, even if it's in the belly, so this verifies that. So the case starts off with a 70-year-old female who was from Bosnia originally. She came into the hospital with 2 to 3 weeks of progressive shortness of breath, not really able to walk much from her bedroom across to the house. Also noted some abdominal fullness, distension, not really abdominal pain, just the sense of fullness and early satiety. And she also noted some low-grade fevers, no cough, no nausea, vomiting, no diarrhea. Her past medical history was significant for psoriasis, and she actually had pretty severe psoriasis that had been long-standing. and it actually was maintained on Humira, which is a very potent medication that suppresses your immune system. It's actually a TNF inhibitor, and she had been on that for the last year. She also had high cholesterol. The medications were, as stated, really nothing significant in the family history. In the social history, as I mentioned, she had immigrated from Bosnia about 20 years ago, and once arriving here, hasn't really traveled outside of Indiana. She had a history of BCG vaccination, which is very common, but really denied any known exposure to anybody with tuberculosis and had no pets. So on exam, her vitals at a presentation were unremarkable. She did have decreased bilateral breath sounds and the bases. Her abdomen was soft but distended, and per report, you could palpate a fluid wave. She also did have some lower extremity edema as well. Her labs really were unremarkable. Her white blood cell count was normal. She was mildly anemic with a hemoglobin of 10. Her BNP and her liver function tests were normal. And prior to starting the Humira, as recommended, she had had a T-spot, and that had been negative. So initially, in late or mid-December of last year, she came in, and the chest X-ray, as you can see here, shows bilateral pleural effusions. The right side has a little more than the left side here, but really nothing in the actual lung parenchyma. There's nothing up here where you traditionally, consider TB. And the CT of her chest was done to further look at that, and you can see you do see the pleural effusions that are bilaterally, and also note it was an enlarged lymph node in the mediastinum. Because of the abdominal fullness, and she ended up getting a CT abdomen pelvis, which really shows this rather distinct blurring of the anterior peritoneum with the bowel wall. This should be a pretty marked, sharp line, and you see that's very blurred here. And as you scan down, she actually did have quite a bit of ascites, and I think that's what had led to a lot of the abdominal fullness, was that she had a lot of fluid inside her belly. So the radiology read was bilateral pleural effusions with moderate ascites, suspected peritoneal metastatic implants, would consider occult ovarian cancer or colon cancer or breast malignancy. Again, common things being common in a 70-year-old woman. So when she came to the hospital, she had an appropriate workup done. She had a paracentesis, and the fluid analysis showed that it was portal hypertension, non-portal hypertension related, and it was mostly a lymphocytic effusion. The cytology on that fluid was negative. The AFP stains were negative, and of course the cultures were sent and pending. She had a thoracentesis done of the fluid around her lung, and the fluid analysis there showed that it was exudative, again, lymphocytic. The cytology was negative, the AFP stains were negative, and the cultures were sent. And then also she ended up getting a transvaginal ultrasound, and this showed a large amount of ascites, a large uterine mass. The ovaries were not well visualized, and she also ended up having an elevated CA-125, which is a cancer marker, tumor marker that's commonly associated with ovarian and uterine cancers. So with that elevation, in that test, and with the findings on the CT scans, really the working diagnosis that most everybody was working towards was that this was likely metastatic ovarian or uterine cancer with peritoneal carcinomatosis and pleural effusions. So to really confirm this, she actually needed to get tissue and actually confirm that. So she ended up getting an omental biopsy done in late December, and the pathology on this showed non-caseating granuloma and did not show any evidence of cancer. AFP stains were negative on that as well. And since there was still no really confirmatory diagnosis yet, she ended up going to the OR early of this year, where she had a DNC and laparoscopy with a peritoneal biopsy. So this is not our patient. I wish we would have had awesome photos like this from the actual surgery, but this is very similar to what is typically seen. And the surgeon describes that she saw peritoneal surfaces with diffuse inflamed miliary changes, no dominant masses seen. This process is likely infectious or neoplastic in origin. What you